It's time now for the award-winning #1 local talk show in Northeast Pennsylvania, The Sam Lesante Show. Now here's your host, Sam Lesante.
So, my friends, he was voted the best surgeon 3 years in a row by the Citizen Voice. Unsolicited readers voted this man the best surgeon in northeastern Pennsylvania. Probably, I think, in the country. You know who he is. He's been on this show for 13 years. My good friend, I call him my brother, Dr. Thomas Meade, one of the leading surgeons in the country. It must be nice, huh? To have, you're starting to get more important to me, Tom.
Sam, thanks for inviting me. I always love being here. So, how you doing?
I'm doing great. You know, and you know, with you with Coordinated Health and the things you guys are doing, and we're going to have an exciting show today because we're going to talk about innovative stuff, which doesn't surprise me, Tom. Doesn't surprise me about Tom Meade. The thing, you know, we have this opioid problem in the country, and you know, you along with a lot of docs from Coordinated Health have been able to address this. It's serious, but a lot of people suffer from knee pain, and they're afraid to get involved with it. So the topic of our show, I thought, would be opioid-free outpatient total knee joint replacement. Tell me what that's all about.
Well, Sam, there's about 1 million total knee replacements done every year. It's certainly the last resort for people with end-stage arthritis after they go through all of the other modalities, the anti-inflammatories, the injection of cortisone, the injection of hyaluronic acid, lifestyle changes, weight loss, braces, ambulatory device. When all that fails, they end up needing surgery. 1 million of these cases are done every year. For decades, the only option that we had for postoperative pain control were narcotics, dangerous narcotics. But it was a great pain reliever for postoperative pain. What we didn't know is how big of a crisis this was in this country. And certainly there's a lot of finger pointing to go around, certainly. But physicians are one of the root causes. The way that we were taught to prescribe opioids, we were certainly informed by the pharmaceutical companies that these aren't as addictive as they are. We know now that it's a horrendous problem. More people die from narcotics every year than car accidents. So as part of our techniques, we had to figure out how to change that parameter. How do we change something we've done for 30 years? So you know, when I started, knee replacements were in the hospital for 7 to 10 days. Then they went into rehab. How could we ever do this as an outpatient if we didn't get pain under control and figure out what to do with narcotics? So right now, 80% of all of our knee replacements that I do are done as an outpatient. They go home not only the same day, but within 4 hours of surgery and with minimal or no narcotics. You know, how did we do this? It was
how did you do that?
It was an evolutionary process. So we had to come up with protocols and powwow with our anesthesiologist and figure out what other non-narcotic medications are out there. And really, it's been a learning curve, and we've figured out how to start even 30 days ahead of time with anti-inflammatory supplements, and then add simple over-the-counter medicines at the right dosages, like acetaminophen or Tylenol, anti-inflammatories like Advil or Aleve. But all of this is done preemptively before the surgery. Historically, we just waited till you wake up with pain and give you narcotics. So it's, to this day, I'm absolutely amazed that we've instituted these pathways and protocols. Walk into the recovery room and you'll see a couple videos where people are up and they have no pain and they're walking. It absolutely amazes me after 30 years that these are not only they are effective, they have less pain, less side effects, and you know, we're contributing to eliminating our component of the opioid crisis in our patients.
Well, you know, it's interesting because when you're talking about this, many people who have gone through the surgeries, outpatients, what we're going to show a video right now, folks. You're going to enjoy this video. I saw it. This video is of a patient 2 weeks after.
Backwards.
You'll be thinking you were drinking, bro. This is April 9th, 2019. 2 weeks post-surgery on the left knee by Dr. Thomas Meade. There it is.
Now there's a happy camper. Okay, now here's a guy, 2 weeks after surgery. I can see he's a little excited, Tom. He feels a little excited about it. So tell me about his story prior to coming here. What pain was he in, and what were some of the concerns he had?
So again, he went through all of the non-operative options, the conservative options that I reviewed a few minutes ago. The injection stopped working, the anti-inflammatories. His quality of life was impacted, but he heard about our opioid-free rapid recovery outpatient total joint program. He's from over 3 hours away up by the New York border. So he came down and he liked what we had to say, and we set him up as an outpatient. So he went home actually within 2 hours of the surgery. He had no pain, went home, and I felt bad he lived 3 hours away. Usually we see these patients back in a week or so. And I said, you know what, if you're doing pretty good, just send me a picture of your incision. And you can see he has the original Band-Aid, or that's a large Band-Aid incision. I said, just send me a picture of that at 2 weeks. We'll talk on the phone. And this is what he sends me. So he's ecstatic. So this gentleman is 73 years of age.
You're kidding.
So he came down. He had our rapid recovery surgery. He showed up at 6 o'clock. We started the surgery at 7. We were done before 8, and he was out the door by 10. He had a 3-hour ride home. He was home by 1 o'clock. He did his own, we have a home physical therapy program where he did his own physical therapy. A therapist didn't come to the house. He took no narcotic pain pills, and he went home the same day of surgery. And obviously he was showing off a little bit. And not every patient looks like this at 2 weeks, but it just goes to show you, we shake our heads at every step of this rapid recovery outpatient program with minimal or no narcotics. And so he's at 2 weeks looking like this.
I know a few people who have knee pain, okay, and they're considering that they don't want to, because of the downtime, and they're afraid of this. So who is an ideal patient for this outpatient? Because I'm sure not everyone is qualified to be in the out. How do you determine what degree the person should be to have this outpatient?
So we have an outpatient selection tool. So it's actually a mathematical algorithm where they answer a series of questions and they get a score. And if their score is between 30 and 34, then 99% of those patients are basically guaranteed to go home successfully as an outpatient total joint arthroplasty. If they get a score between 25 and 30, then it's at the surgeon's discretion. Just through our experience, if they can be outpatient or inpatient. But right now, only about 20% of my patients stay in the hospital. And we have one of those videos today, and only because he had a pulmonary and a previous heart problem, so we thought it was safer if he stayed overnight. In retrospect, he could have went home, but we don't take any chances with our patients. So we do have a patient selection tool that allows us to predict prospectively which patients will successfully do this. But don't get me wrong, I am not promoting knee surgery for all these arthritic patients. We do everything we can to avoid surgery. This is the end of the waterfall, only if everything else fails. And I don't want to give unrealistic expectations that we have the crystal ball and everybody is going to look like this at 2 weeks. It's still a serious operation, and to be taken very, very seriously, with a long conversation going through your individual risks. Everybody has different pain thresholds. But it is exciting to see a majority of our patients do very well, but most importantly, avoid a majority of narcotics that we had in the past. And what pushed this is the opioid crisis. Medicare has approved total knees as an outpatient procedure. That only occurred last year. Before that, you had to be in a hospital. What else pushed this outpatient procedure? Hospital-related medical errors. Some estimate that the third leading cause of death is still hospital-related medical errors. 300,000 to 400,000 people a year die from hospital-related medical errors. And the fourth is side effects of prescription medications are the fourth leading cause of death, equal to that of strokes. So when you add those things together, along with the cost of doing an outpatient total joint versus an inpatient is 40 to 50% less costly. So when our national debt is tremendous and we have a great liability commitment to CMS and Medicare, anything we could do that increases value, improves the outcome, lowers the complication, and costs less, it's only common sense that we're pushing the needle. This is where it's going to go in the future. It's estimated by 2026 by SG2, one of the largest think tanks in the country, that only 10% of the patients will be inpatient. 90% of the patients could be done as an outpatient.
Who is a candidate for this surgery?
So, well, who is a candidate? Again, we have this patient selection tool. So basically,
How do I know that I should be seriously thinking about knee surgery? It's a stupid question.
It's not stupid. Your life is miserable because of knee pain,
Yeah.
and you've exhausted all other options. That's
Right.
the quick answer.
Right.
Your quality of life is miserable. Activities of daily living, most folks will state they can't walk several blocks. They go to the grocery store, they use the cart as a walker. They go up the steps one at a time, sometimes on all four. They come down one at a time. They come down backwards. They've exhausted that list of non-operative treatment, and they say, you know what, I don't like my life the way it is. What can be done? And then not 100% of people are satisfied after a knee replacement procedure. If you look at surgeon-reported results, everybody does great. We're great surgeons. 95% of people do well. But it's really not true. If you look at patient-reported outcomes, probably only 80% of patients report that they were satisfied with their knee replacement. So you better, be pretty miserable before you decide to have a knee replacement. If you have a 10 or 20% chance, of still having some discomfort. So you want to be honest with patients.
I would always think that, again, you're looking, as I say to many when I'm interviewing doctors, I'm the biggest baby walking the face of the earth. You're always nervous about what's going to happen. But with your expertise for many, many years, and you didn't gain this reputation because you don't know what the hell you're doing, all right? So what I'm looking at, if there's a person out there that has knee pain or, like you said, not enjoying their life, it's worth a call just to come in to get examined, correct?
Exactly.
So folks, I'm going to give you an 800 number. It's 877, Sammy put this up, 877-247-8080. And when you call that number, just hit the appropriate area where you want to talk to maybe Dr. Meade's secretary or get some information. And when we come back, we have more videos for you. This is fantastic. This guy is 6'7". Now what happened to him? We'll be back right after this. Welcome back to the Sam Lesante Show. Remember, folks, 24/7. Download our app, SSP TV. All of our original programs on here. 21 covering from north of Harrisburg all the way to the New York border on number of cable systems. Comcast 190 in the greater Pottsville, which hits down to Pine Grove. Channel 190, 7 to 11 p.m. every night. On Service Electric Cable Communications in the Mountaintop, Wilkes-Barre and Kingston area, Channel 92. Saturdays and Sundays from 7 to 11. And of course, Lackawanna County covering Pittston and all the way up to the New York border on Comcast 190. Sunday and Saturday mornings from 8 to 11. My guest today, voted the best surgeon 3 years in a row by readers unsolicited. And he is a friend of mine for many, many years. He's like my brother. He's been on this show for 13 years. Dr. Thomas Meade, a leader in orthopedic surgery. So, Tom, we're talking about this opioid-free outpatient total joint replacement, and we showed one video of this guy after 2 weeks. Now, we have a 6'7" person here, and folks, I want Sammy to show you this video, and we'll tell you all about it.
Can I get you anything with your water?
He's a clown.
Okay, yes, there's that.
2 hours after surgery, the results of Dr. Meade.
Yeah, right.
There you go.
He's great.
Adios.
And he's 6'7".
I know.
Yeah.
He's a
All
tall
right.
guy.
Keep your leg up down when you sit down.
Hopefully it's not the pain pills, but it just feels good.
Yeah, you look good. Let me
Yeah.
see you sit down with your leg out the way you're supposed to. Keep that leg out.
Make me nervous.
Keep it out. Yeah. Keep the leg out. There you go. Perfect. Good. He can listen.
Yeah, he can. When he
2 hours after surgery, 6'7". Tell me about this guy.
Sam, I video these patients on a regular basis because, you know,
Seeing is believing.
well, you would think, you know, we just started operating a year ago, but after 30 years, this is one of the most amazing things I've seen in the world of knee arthroplasty. You just saw a gentleman 2 weeks after the surgery, and you wonder what he's like an hour after the surgery. This is 2 hours after the surgery. This gentleman is 20 years younger. He's in his 50s, but obviously he's a very tall man that puts a lot of pressure on his knees. And you can tell by walking, you know, he's a touch knock-kneed, so he's going to put more pressure on the outside of his knees with that size over the years. And he reached the end of his road, but he didn't want to be in a hospital. He certainly is of the younger generation. He's very familiar with hospital related errors and side effects and wanted this as an outpatient. And so we plugged him into our outpatient rapid recovery program. It's critical, it's absolutely critical that we educate these patients. We require them to go to a 1-hour course. We give them a 60-page handout that's like a Bible. So we reiterate every step of the way. They're not walking into a black hole. We think an educated patient is critical to the success of this procedure. He didn't have general anesthesia. He had a 2-hour spinal. He took all of our supplements, all of our anti-inflammatories, all of our non-narcotic medications before that. But also, what's crucial is intraoperatively, and what's a game changer is like you went to the dentist today and they injected your gums with the type of Novocaine that lasts 2 hours. We don't do a block on their leg. As you see, he can walk, but we do use a new type of long-acting Marcaine or a type of Novocaine that can last 2 to 3 days. So they get over the hump with this. So there's been a lot of game changers in what we've learned and how to get people up after an hour or two and out the door. So, but that's his story. That's what these people look like. I video it every day, not because I'm doing a TV show, but my team just sits there in amazement. And we shake our heads after an hour prior to this. He's had a minimal incision, but it's still a real incision. His knee is wide open. We're putting metal and plastic parts there, and he's up walking, and he's out the door in the car.
What's your technique? What's the technique here behind this surgery?
So that's a great question. So, you know, this isn't just about narcotics and non-narcotics. This is a whole program of patient education. They have to understand the pain pathway. Why are they taking supplements a month ahead of time, such as fish oil, omega-3 fatty acids, L-arginine? These enhance wound healing. They decrease inflammation. Everything that decreases inflammation decreases pain. But additionally, our techniques have changed. Frankly, the operation, the prosthesis isn't a whole lot different than when they were invented, 30, 40 years ago. But our knowledge of how to treat tissues, we call it minimally invasive surgery. It's not the size of the incision. It's how we treat the tissue in a kind manner. We don't open it up like we used to, a foot-long incision for exposure. We don't cut tendons like we used to. We don't use a tourniquet, or we use minimal tourniquet time. In the old days, if you take 2 hours to do the operation and a tourniquet is up for 2 hours, it causes immense pain. So it's all of the different techniques that we use. Minimal incisions, not dislocating the kneecap, being very gentle with the tissues. If we're gentle with the tissues respond kindly. They don't release all the inflammatory mediators. So it's just not changing from narcotics to non-narcotic medications. It's a whole systematic approach to engaging the patient, educating them ahead of time, having everybody on the same pathway, making sure they're compliant with their preoperative supplements, medications. As a surgical team, we're using minimally invasive techniques. We use the old modalities of rest, elevation. We don't do as much aggressive physical therapy right after surgery. The old days, we'd have them on these CPM machines and we'd move them back and forth. Well, we found the same thing, that if we put the patient in control of doing exercises 5 minutes a day for the first couple days or the first week, that's 40 minutes of exercise spread over the day instead of 40 minutes of exercise in an aggressive therapy program. So this whole comprehensive educational rapid rehab program is what's critical. But we also do it for the 10 or 20% of people that stay in the hospital. They're on the same exact program. Just because they're in the hospital, which may be because they have a previous cardiac event or they previous smokers and they have pulmonary issues, we want to keep an eye on them overnight. We treat them like they're home. They're out of their pajamas. They're up walking around. These patients are not sick. They have a sore knee. So we have to educate that mentality. It's very hard to get over. But I said, you're not a sick patient. You're a healthy patient with a sore knee. So you don't need to be in a place of sickness called the hospital. You come in and now you are a healthy patient with a sore knee because we operated on it. So you're going to get up and you're going to go home as a healthy patient. And now you're going to have a sore knee, but we've educated you on what the pain is going to be like hour 1, day 2, day 3, day 4, and they expect it. So it's a lot of effort to educate them, but it's a real comprehensive program. It's just not converting from narcotics to no narcotics. And of course, they do get a small prescription of narcotics, so nobody at the third day says, Dr. Meade's crazy, it hurts, I need something else. But they're not getting 150 Percocets to go home with.
Tom, you know what you should be recording?
What?
The story of why they hesitated and the fear that they had going to you and getting the surgery, because as I said, once I have friends of mine who are in pain and they're concerned, they're fearful, so these people, I'm sure you have these, I'm sure they said, Dr. Meade, I should have done this a long time ago. I'm sure you must hear tons of stuff.
The number of people that say, I wish I did this 5 years ago,
yeah.
but I will preface that with fear is good, and patients shouldn't rush into that just because they've had a lot of pain, their life was disrupted. I always say the worse you are, the better result you will have, because it's easier for us to make that decision. The hardest patients that we have are our active 40 and 50-year-old patients that have a little knee problem and they can't play 2 rounds of golf, or 3 hours of basketball. And they say, after playing singles tennis, my knee hurts. I would like a knee replacement so I could go out. I go, that is not the reason. You do not need a knee replacement. You need an evaluation. You need to be treated for some early or moderate arthritis. A knee replacement is down the line. So you have to be careful that we don't overhype this thing. I just want to be very, very clear with that.
Folks, I'm talking with Dr. Thomas Meade. Number on the screen, 877-247-8080, to talk about, if anything concerns you have. However, we come back, we have another video, and we have Dr. Meade is conducting an interactive town hall in Jim Thorpe on Monk Chunk Opera House on April 30th. We're going to talk about that and why you should go there if you have some concerns. We'll be back after this. Welcome back to the Sam Lesante Show. My guest, Dr. Thomas Meade, no stranger to SSP TV. Been on the show 13 years, the Dr. Meade Show, Real Life in the OR, and now this Coordinated Health shows you with Coordinated Health. Dr. Meade, we're talking about the outpatient total knee replacement, most importantly, opioid-free. Folks, here is another video we want to show you of a person a day after this surgery. So let's show it.
I went home the next day, and at 11 o'clock in the morning, I walked up 16 steps in the back of my house. Little different walk because you walked with the good leg and dragged up the bad leg. But I was able to climb 16 steps without any complication. The day after surgery, and people are telling me, how the hell can you do that? I didn't perform miracles, but you did.
Yes, thanks. Anyway, so let's get started on the other knee, okay?
Okay.
So that's a day after the surgery. What was this story?
So this is an example of our rapid recovery opioid-sparing total joint program, but the patient stayed overnight. He had a cardiac history, a pulmonary history. He's an accountant, so he's pretty sedentary, but he was ecstatic. So we treated him just like he was home. He got up, he didn't lay in bed all day, he walked around afterwards, but he came in the office and he said, I have to tell you, I can't believe that, I went home the next day. I live on the second floor. I walked up 16 steps. He said, my knee feels like it did when I was 23, which is pretty amazing.
What happens at these interactive?
Yeah, I'm happy to be a guest at the Mauch-Chunk Opera House. I love that place.
Oh,
I love the history. And I love being on your show, but I really love doing this better.
Yeah.
I know you're going to be insulted. I love talking to people in public. I've done it for years. And whether it's at a restaurant, whether it's at a church, or it's a community hall, I could interact with people. So we're going to discuss exactly what we discussed today, but people have a chance to come in. And we're really not incentivizing them. Usually we give them something to eat for dinner, but in lieu of that, so we're going to give them a food voucher to go next door at the Molly McGuire's pub and get a bite to eat or bring it in. And we also have some of our supplement sponsors are going to be there to provide information about the supplements that are critical, that we didn't learn about in medical school, but it's absolutely critical. I think it's going to be more informative. So it's really going to be a lot of information about the supplements, and people can decide, in their, and you can use this in other surgeries if it's approved by their surgeons.
Well, I agree with you and I disagree with you. I agree with the interactive town halls, but I disagree about being on the Sam Lesante Show because you certainly get a lot of information. Folks, it's important if you have any knee pain whatsoever. This is innovative stuff. Dr. Meade's been doing it, and he's been voted the best surgeon 3 years in a row. Tells you something. I'm very proud to say he's not only a great surgeon, but he's like my brother, and I trust him dearly, and I think you'll do very well.
Thank you, Sam. It's always my pleasure.
It's always a pleasure. Folks, we'll see you next time.